Bismillahirrahmanirrahim. The key to success is to focus on goals, not obstacles. Today, my topic of presentation is typhoid, also known as enteric fever. Learning outlines. Introduction. Learning outlines of the presentation are introduction, epidemiological factors, chain of transmission, clinical manifestations, level of prevention, and recent advances. At the end of the presentation, students will be able to describe the epidemiological aspects of typhoid, preventive aspects of typhoid, national and global updates, and recent advances. So what is typhoid? Typhoid and paratyphoid fevers are commonly grouped together under the collective term enteric fever. Typhoid fever is caused by Salmonella typhi and paratyphoid fever is caused by either Salmonella paratyphi A, B, or C. Both S. typhi and S. paratyphi cause a fecal oral transmitted systemic disease, but Salmonella paratyphi causes a less severe illness. History. Carl Joseph Everett was the first to describe bacillus that was suspected to cause typhoid in 1880s. 4 years later, George Kafke was the pathologist that confirmed this link and named the bacillus as Everett typhi, also known as Salmonella enterica. One of the biggest epidemics of typhoid fever were between 1906 and 1907 in New York. Mary Mellon, uh, often referred to as Typhoid Mary, spread the virus to 122 New Yorkers during her time as she cooked. And she was the well-known chronic carrier of typhoid fever. Problem statement. WHO has estimated the burden of disease from 11 to 20 million cases annually, resulting in about 128,000 to 161,000 deaths per year. Typhoid is endemic in Asia, Africa, Latin America, Caribbean, but 80% of cases are reported from Bangladesh, China, India, including Nepal, Pakistan, and Vietnam. Typhoid is high-risk populations are populations that have poor sanitation and inadequate water supply, clean water, and poor communities, especially the children, are at high risk. This is the graphical representation of the distribution of typhoid fever globally, and it mainly includes the African and the Eastern Mediterranean regions. Red areas, dark red areas shows the high incidence of typhoid fever with more than 100 cases per 100,000 per year. In Pakistan, recently there has been an outbreak of extensively drug-resistant typhoid fever that began in Hyderabad district in 2016, and increasing trends of typhoid fever caused by antimicrobial resistant strains of Salmonella typhi poses a notable public health concern. In from November 2016 to December 2018, total 8,188 typhoid cases were reported in the province Sindh, out of which 5,274 cases were of extensively drug-resistant typhoid. This circulating strain of extensively drug-resistant typhoid is resistant to first, second, and also the third line cephalosporins that are mainly used for the treatment of typhoid fever. There were also reported cases of extensively drug-resistant typhoid strains that traveled to Pakistan internationally. These are the figures and the number of cases. From November 2016 to December 2018, out of which 69% cases were reported in Karachi, 27% cases in Hyderabad district, and 4% cases were reported in other provinces. Now, epidemiological determinants. As I have mentioned before, that the agent is Salmonella typhi. It has three types of antigens, O, H, and VI. And the factors that influence the onset of typhoid fever in man are virulence and the infected dose. It's a gram-negative bacilli and it's a facultative anaerobe and is distinguished from other bacteria by biochemical and antigen structure. Among the host factors, typhoid fever may occur at any age, but highest incidence of this disease occurs in 5 to 11 years of age. But the children under 2 years of age and infants are also at equal risk of being infected by typhoid. That is why campaigns are being run in Pakistan as well in other countries where typhoid is endemic, and uh, vaccination is being included in the routine immunization programs to combat this extensively drug resistant typhoid in endemic and highly affected countries. Among the environmental factors, typhoid fever is usually reported with peak incidence during July and September. Bacilli can be found in outside the human body in water, ice, food, milk, and soil, but typhoid cannot multiply in water and will perish within 48 hours. But some may survive about 7 days. And vegetables that are grown in contaminated water are positive health hazard. Sewage water. Incubation period usually ranges from 10 to 14 days, but it may be as short as 3 days, or if 3 weeks depending upon the dose of bacillus ingested. What are the modes of transmission? Two main modes of transmission: fecal oral route or indirect by ingestion of contaminated food, water, and milk. The 5 F's are very important in the chain of transmission of typhoid fever, that includes flies, finger, feces, food, and fornication. There are two main primary sources of infection: feces and urine, or by cases and carriers, and the secondary sources are through contaminated water, food, fingers, flies, and there is no evidence that typhoid bacilli are excreted in sputum or milk. Reservoir of infection. Reservoir of infection is man is the known reservoir of infection with cases and carriers. Now, what are the case definitions and the classification of typhoid fever cases? What is a suspected case of typhoid? According to WHO, suspected case of typhoid is the one in which there is fever for at least 3 out of 7 consecutive days in an endemic area or following travel from an endemic area, or there is fever of 3 days out of 7 consecutive days within 28 days of being in household contact with a confirmed case of typhoid or paratyphoid fever. Now, what is a confirmed case? A confirmed case of typhoid fever is having a clinically apparent disease with laboratory confirmation by either culture or molecular method of Salmonella typhi or detection of S. typhi DNA from the normally sterile site. Similar is for the paratyphoid fever with laboratory confirmation by culture and molecular methods. And third is the relapse of typhoid and paratyphoid fever. Laboratory confirmation of Salmonella typhi and paratyphi from the normally sterile site, but the difference from the confirmed case is that within a month of completing an appropriate course of antimicrobial treatment and the resolution of symptoms, the symptoms recur and there is the laboratory confirmation of Salmonella typhi and paratyphi in the blood culture again. This is the tabulated form. I have discussed it already. Now, what are carriers? There are two types of carriers. Temporary carriers that include incubatory and convalescent carriers, and the chronic carriers. First, I will discuss what are chronic carriers. Chronic carriers can be divided into two uh, parts: presumptive carriers and the definitive chronic carriers. The definitive presumptive carriers, there is the duration of the secretion of the bacteria in the stool or urine is not known, but in definitive carrier, we say that if there is an evidence of Salmonella species in stool at least for 12 months or more than a year after the appropriate course of antimicrobial treatment and the resolution of symptoms, then we will label it as a definitive chronic carrier. Or we can say that there are two positive stool samples 12 months apart. Convalescent carriers are usually carriers that shed the bacteria for 3 or more months after the onset of acute illness. Similar is for the incubatory carriers, but they only shed the typhoid during the incubatory period. According to WHO, convalescent carriers are defined as Salmonella species for 1 to 12 months after finishing an appropriate course of antimicrobial treatment. The only difference between this convalescent carrier and the chronic carrier is the time duration. This is less than a year or 3 to 8 months, but in chronic carriers usually more than a year or several years. Here is a difference between cases and carriers. You can see that temporary and incubatory carriers excrete bacilli for approximately 6 to 8 weeks, but chronic carriers excrete bacilli for more than a year, and they may either persist in gallbladder or biliary tract. And typhoid Mary uh, is the excellent example of this chronic carrier. Now the levels of prevention. Primary prevention is through health promotion and specific protection. We can prevent and control typhoid fever through key interventions, including hygiene promotion that includes good hand washing practices, avoiding food from street vendors, control of flies, and avoid undercooked meats. We can also improve water safety and use safe water for all purposes. For example, we can boil water for before consumption, better sanitation infrastructure, and ensuring adequate and timely access to patient care so there are less missed cases of typhoid fever. Specific protection is through vaccination. According to WHO, three types of typhoid vaccines are licensed for use. The newer generation typhoid conjugate vaccine is currently being used, especially in the areas where typhoid is endemic or there are outbreaks of typhoid, and it is a VI polysaccharide antigen linked to typhoid tetanus toxoid protein. Second one is unconjugated VI polysaccharide, and third one is the live attenuated. First two are the killed vaccines. The orally administered vaccine, TY21A vaccine, is live attenuated, usually recommended for children more than 5 years of age. There is a 3-dose regime. The capsule is given on first day, third day, and fifth day, and the protective immunity is achieved after 7 days of the last dose. Recommended temperature for storage is +2 to +8 degrees. The unconjugated polysaccharide vaccine is licensed to use for children less than 2 years of age. Single dose is required, and a booster dose is recommended every 3 years. The typhoid conjugate vaccine is a polysaccharide vaccine that is conjugated to tetanus toxoid. It is given intramuscularly, single dose 0.5 ml, and can be given to children of more than of 6 months of age up to adults of 45 years of age. Studies have shown that typhoid conjugate vaccine is safe, effective, and can provide protection for infants and children under 2 years of age. This typhoid conjugate, the reason for using this typhoid conjugate vaccine is that another reason that it provides long lasting immunity and requires fewer doses, and is suitable since it is suitable for children using under 2 years of age, so we can add it in the routine immunization programs to help pave the way for national authorities to combat typhoid in endemic areas and the areas where there are outbreaks of extremely extensively drug resistant typhoid. In Pakistan, two vaccines against typhoid are currently available. A single dose injectable VI polysaccharide vaccine for children more than 2 years of age, and a single dose typhoid conjugate vaccine is being used for children of more than 6 months, and it offers the protection for at least 3 years to adults, children, and infants. And neither vaccine is 100% effective and would require repeat immunization, and vaccine effectiveness diminishes over time. Now, the secondary prevention is by early diagnosis and prompt treatment. How does the typhoid fever, the acute illness of typhoid fever presents? The main clinical features of typhoid fever during the first week includes malaise, headache, cough, sore throat with prodromal stage. And it is over 4 to 5 days. It is accompanied by a higher temperatures with a step ladder fashion with headache, abdominal pain, constipations. During second week, um, there is a significant finding with relative bradycardia and rose spots are seen on the body. During the third week, there is a typhoid stage which states for prolonged apathy, toxemia, delirium, disorientation, and may result in coma. And if left untreated, there is a high risk of 5 to 10% of intestinal hemorrhage and perforation. That is the most common complication of typhoid fever. Other complications include pneumonia, thrombophlebitis, cholecystitis, nephritis, osteomyelitis, and 2 to 5% patients may become gallbladder carriers. Among the diagnostic criteria or diagnostic techniques, under the heading of microbiological diagnosis, blood culture is the gold standard test for diagnosis of typhoid and must be sent before starting the antibiotics. The culture is mainly done from blood, bone marrow, urine, and duodenal aspirates and stool can also be used for the specimen. Negative culture does not exclude typhoid and may warrant a repeat blood culture if the fever is not responding in 7 to 9 days of commencing treatment. Serological tests like Budol and Typhidot are not recommended nowadays for the diagnosis of typhoid because of the low sensitivity and specificity, and it do not provide information on antimicrobial sensitivity. Since the appearance of mutated strains of typhoid that caused extensively drug-resistant Salmonella typhi epidemic in Pakistan during 2016, the management of typhoid fever in Pakistan have become a huge challenge. In treatment of typhoid fever, we treat the patients as cases and carriers. For cases, the drug of choice are fluoroquinolones that are widely regarded as a drug of choice for treatment of typhoid fever. The reason for using such drugs is that they are relatively inexpensive, well tolerated, and more rapidly and reliable effective than the former first-line drugs like ampicillin, amoxicillin, and sulfamethoxazole. These are the classification of drugs that are mainly used in typhoid fever: first line antibiotics, second line antibiotics, and third line antibiotics. The commonly used drugs for uncomplicated typhoid cases is ciprofloxacin, azithromycin, chloramphenicol, and the doses are shown in the table. And for severe typhoid, cipro is preferred with ceftriaxone and cefotaxime. For carriers, the drug of choice is ampicillin or amoxicillin with intensive courses of 4 to 6 grams per day together with probenecid for 6 weeks or more. And the eradication of carrier rate is about 70%, and the carrier should be kept under surveillance, and they should be prevented from handling food, milk, water for others. Now, these are the case definitions for the typhoid fever cases after the extreme drug resistance epidemic in Pakistan. Non-resistant typhoid is classified as the typhoid cases who are sensitive to first-line drugs and third-generation cephalosporins. Multi-drug resistance typhoid fever is characterized by resistance to first-line drugs. It is sensitive to third-generation cephalosporins with or without resistance to second-line drugs. But extensively drug-resistant typhoid is resistant to all recommended antibiotics for typhoid fever. Now the recent updates. The current state of antimicrobial surveillance in Pakistan is poor and needs urgent attention to both understand and predict future outcomes in antimicrobial resistance. So we thus allows for appropriate antibiotic campaign stewardship if we are to prevent ourselves from going back to the pre-antibiotic era. This is a paper showing how extensively drugs-resistant typhoid has affected Pakistan and how it shows that 21 million people contracted typhoid annually with Pakistan inhabitants at most risk. Same figures are shown that 5 out of 8,188 total cases of typhoid, 5,274 were extensively drug-resistant strains, and it's a huge threat and a problem in our society that due to the extensive and indiscriminate use of antibiotics, the Salmonella typhi strain has mutated and has attained such high level of resistance that it is now difficult to treat typhoid cases in Pakistan. This is the graphical representation of the uh, cases of extreme drug typhoid resistance, with showing highest among in Karachi and then in Hyderabad and the other districts. To combat this problem, first in 2019, Pakistan became the first country to introduce typhoid conjugate vaccine into its routine immunization. This campaign started in Sindh, and the aim was to reach about 10 million children and to vaccinate them against this extremely drug resistance typhoid with typhoid conjugate vaccine. The second phase of this campaign has been started in 12 districts of Punjab and Islamabad from February 1st to February 15th. And the target is to reach 12.7 million children between the age of 9 months to 15 years. And typhoid conjugate vaccine has been started due to high number of typhoid cases, like 8,000 cases were reported in 2020. Now, in relation to COVID, there was a misleading information about Typhidot test. This paper shows that during COVID pandemic, near 20,000 typhoid patients were reported in June 2020. Uh, Typhidot test, by performing Typhidot test, misleads the diagnosis of COVID-19 due to cross-reactivity of antibodies and comes up as IgM positive for Salmonella typhi. This false positive COVID-19 serological test case is raising a false alarm. Now it's time for the MCQs. A massive typhoid vaccine campaign is underway in Pakistan using which type of conjugate vaccine to protect kids from age 9 months to 15 years?
C.
Conjugate
Type
C. Gold standard for diagnosis of typhoid
C.
is
Blood culture.
Culture.
extensively drug resistant typhoid means Salmonella typhi resistant to all types of recommended antibiotics. Step ladder type of fever is seen in
Typhoid.
Salmonella enterica typhi is which type of
Gram-negative.
gram-negative rod-shaped bacteria? Typhoid which is commonly acquired by
A.
A. Drug of choice for treatment of chronic carrier state in typhoid fever is
Ampicillin.
ampicillin. During typhoid fever, relative bradycardia and
Second week.
B.
in chronic carrier state,
B.
S typhi most commonly resides.
B.
The recommended
Plus
storage
2 to plus
temperature
8.
for
B.
B.
this is the key, the references, and thank you.
Thank you very much, Dr. Amber. Very comprehensive presentation. However, I would like you to please announce the results and also tell the correct answer when the students are saying multiple answers. For example, some were saying A, some were saying B. You should have a very clear and loud voice about the correct answer because you are the presenter.
Okay, ma'am.
Okay.
Ma'am,
Next time, please. Next time, please. Okay. Only announce the results, please.
ma'am, Dr. Marine answered the most questions, then Dr. Sadia and Dr. Khansa.
Okay. Thank you very much. As you have said that there are many states and the carrier state are one of those that are very worrisome and they have a pivotal role in the spread of typhoid. And the typhoid vaccines, you have told more about conjugate vaccine. That is good because 9 months to 15 years of age is going to have these vaccines for prevention of typhoid. And as it has been presented that 12.7 million children will be reached during this campaign in 12 districts of Punjab and Islamabad during February, especially in the first 2 weeks of February. However, there are other vaccines that are also available, and we know that it is not the age that is from 9 months to 15 years that is only prone to get typhoid, but there is a great chance of the elders and up to even the old age that people can get typhoid and have these serious complications. The mortality rates are more in children because their manifestations of different diseases, they are usually causing lot of mortality among children, and we in Pakistan are always concerned about decreasing the infant mortality and under 5 years mortality of the children. In adults, as the age groups, they are much wider and up to 45 years, we know that there are many cases that peritonitis that is caused when there is a leakage from the intestine and it is causing the life-threatening condition of peritonitis, and even there are certain cases that are not being saved during surgeries of typhoid peritonitis. Another important thing is about investigation. We know that for decades we have been used this test, withdrawal test, that is not very specific and sensitive. However, it is an agglutination test which detects the presence of serum agglutinins, especially AH and O, in patients' serum with typhoid and paratyphoid. And we have seen that the titers of the patient's serum using withdrawal test in TGN suspensions is the highest dilution of the serum sample that gives a visible agglutination. So usually the report says it is 1 ratio 64, 1 ratio 320, 1 ratio 640, etc. Uh, the withdrawal test should be interpreted in the light of the baseline titers, and as we don't have the baseline titers of majority of the population, so it is of no use in our population. The second important thing that has to be remembered about withdrawal test is that the false positive rates of withdrawal test are very high, especially with acute malaria, nephrotic syndrome, rheumatoid arthritis. There are many conditions like COVID-19 is one of the conditions that can give the false positive rates. In the presentation, it has been correctly said that typhoid dot is one of the tests that has shown uh, false positive results for COVID-19. And again, it is something that has to be noted. So the culture is the gold standard and it is 100% specific. But there are many issues with the culture too. We know that the culture of the bone marrow gives 90% results, and it is even giving the results after 5 days of commencement of the antibiotics. But it is a very painful procedure, so it cannot be recommended as a routine procedure. Another important thing that we have seen about vaccination is that it has to be offered to the carrier. We know that the treatment is also for the carriers. We have antibiotics for the carrier, and it is being presented that at least 6 months of aggressive antibiotic therapy that is required for the carriers. But we also have the chances that the carrier may relapse and they again start secreting Salmonella typhi without having the symptoms. So it should be under surveillance. As far as the vaccines are concerned, we know that there are live typhoid vaccines too. We have been during the presentation focusing more on the conjugate vaccine. Why? Because conjugate vaccine is more in our programs now, in routine vaccination programs, EPI program. Previously, we have 10 diseases that has been covered by EPI program. Now it is the 11th disease that is being covered in EPI program. That is why we are more concentrated our efforts towards typhoid conjugate vaccine. There is another very effective type of vaccine that is available for typhoid, and that is live typhoid vaccine. It consisted of 4 oral capsules, and the one capsule has to be given on every other day. And that, as these are 4 capsules, so the whole course should be completed in 6 days. And that is going to provide the immunity for 5 years, and the booster is required after 5 years. So it has a very good safety profile too. And all those who are advised swimming and any sports activity with water, they must have this vaccine in there for 5 years, because it is they are getting immunity against typhoid. Another important aspect of the typhoid is about World Health Organization, as recent updates have been presented. So World Health Organization has done a lot of work in decreasing the typhoid cases all over the world. And the World Health Organization has said that due to the various factors that can influence the results of a withdrawal test, it is best not to rely too much on this test. So the test that has been mainstay for decades, it has not getting the support from WHO now, and it should not be used. And as we have said, that without diagnosis, the prompt treatment cannot be started. And as the treatment consisted of several antibiotics, and these antibiotics, they have to be through culture and sensitivity report. The correct antibiotic has to be identified. Otherwise, we would have another epidemic of drug-resistant typhoid waiting for us. These are my comments on this presentation. It is a wonderful presentation. If you have any questions, please do let me know. Okay, thank you very much. Now,
Thank you, ma'am.
Allah Hafiz. See
Allah
you next
Hafiz.
time. Allah Hafiz.